Thank you. Hopefully I can coordinate my hands and my mouth at the same time with all these tools. All right. All right, so the objectives for this talk, I think we'll review first the basic function of the kidney and then how mutations in ACTA2 manifest, which I'm sure all of you know. We'll discuss complications of kidney disease and of course, management of the disease and interventions that we can offer. So as a brief overview, I just want to first talk about, what the kidney does, right? I think I'm biased. I think it's a wonderful organ, although I do know it's not as vital as the heart. There we go, heart and the lungs. But I do think, oh, there we go. All right, first, let's go in and out, but whatever. All right, the first thing it does, it regulates the body salts, it filters all the blood. Maybe this one works. Okay. So things like sodium, potassium, chloride, phosphorus, calcium, it regulates all the salts in the body. The kidney also filters the blood to make urine, right? Those are the two common things that we know. So whatever we drink, we have to pee, otherwise we puff up. And then the kidney also has several hormonal functions as well, right? It makes epoetin, which stimulates the bone marrow to make red blood cells and prevents anemia. It activates vitamin D that we absorb from our gut and our diet so that we can get strong bones. And of course, it also regulates blood pressure. And although that is a hormonal pathway, I put it separately just because when you have chronic kidney disease, blood pressure can be altered. So this brings us to our chronic kidney disease population. I guess I put this slide up because we want to know what happens if you do have chronic kidney disease. And this slide basically talks about the different types of disease that leads to end-stage renal disease and transplant in our pediatric population. And this slide comes from the NAPRTIX data, which actually was started in the 80s, and it keeps track of all the pediatric kidney transplants in North America. And you can see here, although this data is still a little bit old, in 2014, there's over 11,000 patients that have been transplanted, and congenital anomalies in the kidney and urinary tract is the most common cause, with over 40 genes that lead to end-stage kidney disease due to congenital anomalies. There are other causes, including nephrotic syndrome, glomerulonephritis, and these are other diseases that affect patients. But for patients with MSMDS, it's mainly going to be congenital anomalies of the kidney and urinary tract. So how does ACTA2 manifest with patients with MSMDS? I guess everybody knows, I just put this as a background slide. It's heterogeneous mutations. Heterogeneous mutations in ACTA2 on chromosome 10. It functions in vascular contractility, especially in smooth muscle, and most commonly affects the arginine 179 amino acid, and typically histidine or cysteine. And it has multi-system effects. That's part of the name, right? Including the vascular system with aneurysms, PDA, ophthalmic manifestations, cerebrovascular disease and stroke, as well as lung disease, GI malrotation. And in the kidney and GU system, we classify it as CACUT or CACUT. It's congenital anomalies of the kidney and urinary tract. So what does that mean? I think it really manifests as secondary effects from the bladder, right? And it can typically manifest either as poorly functioning bladder, or in Raceland's case, even like a prune belly phenotype or sequence with associated cryptocortism or undescended testicles and lack of abdominal musculature. But basically, it leads to a formation of a bladder that cannot empty or contract normally. And as a result, the kidneys then feel these secondary effects and can manifest either as what we call hydronephrosis, which is swelling of the collecting system, kidney stones, UTIs, and eventually chronic kidney disease. And in this slide, I show a couple pictures for people who don't understand what, or don't remember what hydronephrosis is. It's basically swelling of the collecting system. This is a normal kidney with its filtration system and collecting unit. And as you go down from left to right, you can see that the collecting system can enlarge and swell and eventually even cause compression of the normal outer layer. And that's hydronephrosis caused by either obstruction, which can happen from incomplete emptying of the bladder, or even reflux, which can also happen in patients with ACTA2 mutations. And both obstruction and reflux can cause damage to the kidney for various reasons. And on the right side, we have a CT scan showing a kidney stone right there and right there in the ureter and the kidney tissue. And kidney stones often can develop in patients with urinary stasis. So if the bladder is not emptying properly and urine is not moving regularly, stones can develop as well. And so I guess in talking about management of disease, right, there's several things we want to talk about. I think first thing is about monitoring and treating urinary tract infections with patients with UTIs and kidney stones. And why do we care about that? Well, I mean, we already talked about, Liddy talked about with Weizhen's case, it's not just the UTI, right? It can lead to ICU admissions and complications. But from UTIs itself, this figure comes from the AAP guidelines on UTIs, and it shows that from this study in the 80s, right, the more UTIs you get, the more risk of renal scarring there is. And I also included this article from 2019, the more recent article, which actually showed that with newer technology, we can actually show that even after the first UTI, right, there's an increased risk scarring of not 5 or 10%, but closer to 26%. So UTIs are important to manage and treat because we worry about kidney function if there's recurrent infections and scarring. In regards to kidney stones, right, there are some patients with kidney stones. There are some things that we can do. This is very generic for any patient with kidney stones, but we have some things in our toolkit, including 24-hour urine collections, laboratory values, as well as some treatments, which include dietary approaches with water and salt intake. We can recommend changes in supplements regarding changing what the urine looks like. And of course, diuretics, which can help hold on to calcium in the blood and prevent it from getting into the urine. And all these things we can use depending on what we see in the patient's blood and urine to individualize the approach towards preventing further kidney stone formation. So we've talked about monitoring and treating UTIs and kidney stones. We also talk about managing any degree of CKD, right? For example, we talked about in the first slide, the different functions of the kidney. And so if the kidney function declines, you might see dysfunction in electrolytes. You might see a difference in urine output, which can affect volume status. We can talk about the different issues regarding lack of hormonal function. You can have anemia, poor bone health, hypertension. And we'll talk about how that affects in ACTA 2 patients. But on the right, you can see that all these things can decline over time. And there are many different stages of kidney disease. And we typically don't see effects on the kidney function until the kidney has about 30% or less kidney function. So typically stage 4 chronic kidney disease. But obviously, if we're involved from the very beginning, we'd like to maintain and preserve kidney function. That is our role, so that it never or slowly progresses over time. And so we've talked about treating UTIs and kidney stones, talking about CKD. I think, Dr. Elder as well will next talk about coordinating care with urology, right, regarding the bladder function. I think that we know that the underlying disease causes a lot of bladder issues and all the effects are secondary from the bladder. And so we'd like to make sure that we work with our urology colleagues and the families to make sure that the collecting system and how we empty it is working as well as possible. And I just wanted to mention about the vascular complications as well. And it's actually hypotension that occurs in these patients, not hypertension. But if we wait long enough and there is chronic kidney disease, there might be a component of hypertension that we have to manage as well. So as everyone probably knows, we work together as a team and we work with our cardiologists and urologists to manage every aspect of the child's care. And I was also asked to talk about initial workup as well, what to do if you have a patient who's been diagnosed and how do we manage them. So I think we would recommend initially at least just an ultrasound. We want to look at the bladder, we want to look at the kidney collecting system, the ureters. And based on that, both the urologists and nephrologists will work together. We can consult and come up with a plan. And then for long-term follow-up, I think at least annually, if there's minimal kidney involvement, at least just to check blood pressures, check urines, make sure things look normal. And I guess if there's bladder involvement, we would see them more often, either with, if less than a year, we like to do more ultrasounds more frequently. And depending on the bladder involvement, we may do more functional testing, whether it be to look for reflux, obstruction, which I mentioned earlier, and managing any of the sequelae of disease. And as they get older, depending on how stable the patient is, we could probably space out imaging at least to annually if things are going well. So hopefully in Weizhen's case, we can start slowing things down as things stabilize. All right. And so that's all I have on the kidneys, and hopefully I turn over to Jack next.